Arterial occlusive disease is the obstruction or narrowing of the lumen of the aorta and its major branches, causing an interruption of blood flow, usually to the legs and feet. This disorder, however, can affect a variety of arteries within our body, including the carotid artery, vertebral arteries, subclavian, mesenteric, and celiac arteries. Arterial occlusive disease is a common complication of atherosclerosis. Occlusions may be acute or chronic and commonly cause severe ischemia, skin ulceration, and gangrene. Major risk factors for peripheral arterial disease are cigarette smoking, diabetes, older age, generally older than 40, hypertension, hyperlipidemia, and hyperhomocysteemia. As we said earlier, those occlusions could be acute or chronic. The limb's appearance gives vital information about reduced blood flow. Manifestations of acute arterial ischemia include the 6 P's: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which is an adaptation of the limb to the environmental temperature, and that's most oftentimes cool. So if you detect these signs, you should immediately notify the healthcare provider. Without immediate intervention, ischemia may progress to tissue necrosis and gangrene, sometimes within hours. The severity of peripheral arterial disease symptoms depends on the site and the extent of the blockage and the amount of collateral circulation that the patient may have. Paresthesia, which is numbness or tingling in the toes or feet, may result from nerve tissue ischemia. The limb's appearance also the skin may appear thin, shiny, and taut. That's okay. Oftentimes the lower legs will lose their hair and the pulses can become decreased or possibly even absent. Another sign of the limb not being perfused well would include pallor, which is blanching of the foot, and that will develop when the leg is elevated, and so it is referred to as elevation pallor. On the other hand, we can see reactive hyperemia, which is redness of the foot, and this develops when the limb is in the dependent position, and that is referred to as dependent rubor. The classic symptom of lower extremity peripheral arterial disease is intermittent claudication. This ischemic muscle pain is caused by exercise and resolves within 10 minutes or less with rest and is reproducible. The ischemic pain of claudication is due to the buildup of lactic acid from anaerobic metabolism. So once the patient stops exercising, the lactic acid clears and the pain subsides. Peripheral arterial disease of the iliac arteries causes claudication in the buttocks and thighs. Diagnostic studies for peripheral arterial disease include Doppler ultrasound with duplex imaging and ankle brachial index. Doppler ultrasound maps the blood flow throughout the entire region of an artery. When palpating a peripheral pulse is hard because of severe peripheral arterial disease, Doppler ultrasound can determine the degree of blood flow. The ankle brachial index, ABI, is a peripheral arterial disease screening tool. It's done using a handheld Doppler. The ABI is calculated by dividing the ankle systolic blood pressure by the higher of the left and right brachial systolic blood pressures. We do have guidelines that will help us to determine the degree of peripheral arterial disease based on the ankle brachial index results. Okay, care of the leg with critical limb ischemia is revascularization via bypass surgery using an autogenous native vein. An alternative is percutaneous transluminal angioplasty, or PTA. Bypass surgery allows for the native vein to carry blood around the lesion, and which is demonstrated here, how the graft will then carry blood around the lesion or plaque obstructed area. Interventional radiology catheter-based procedures are alternatives to open surgery for treatment of lower extremity peripheral arterial disease. Now, these procedures take place in a catheterization lab and rather than an operating room. All these procedures are similar to angiography in that they involve the insertion of a catheter into the femoral artery. The PTA procedure uses a catheter that has a balloon at the tip, and the end of the catheter is moved to the narrowed or stenotic area of the artery. The balloon is then inflated, compressing the atherosclerotic intimal lining. Now, stents are expandable metallic devices, and they are placed within the artery after the balloon angioplasty. The stent will hold the artery open. Again, these stents may be coated with a drug to limit the growth of new tissue. And I know some of you were asking me what is the name of the drug, and I had never known that before, but it is listed as paclitaxel. Is the name of the drug that they use, sometimes at least, in coating these stents. Atherectomy is the removal of the obstructing plaque. Okay, they're going to use a cutting device to cut the plaque or mass or lesion, and actually will remove it, break it up, and remove it in that way. Cryoplasty also can be combined with PTA, and it is a cold therapy, and it results in limiting restenosis of that area. Finally, amputation may be needed if tissue necrosis is extensive, gangrenous, or any other severe limits in the blood flow to that limb. Non-surgical therapy for intermittent claudication involves risk factor modification, exercise, and pharmacologic therapy. Based on all available evidence, a supervised exercise program is the most effective treatment. All patients with peripheral arterial disease should undergo aggressive control of blood pressure, sugar intake, and their lipid levels. All available strategies to help patients quit smoking, such as counseling and nicotine replacement, should be used. Here we see a list of some of the effective drug therapies for patients who have peripheral arterial disease. And among them, we have aspirin, persantine. Now, persantine inhibits platelet aggregation, and Plavix, and then Platol and Trentol. Now, peripheral arterial disease is a nice segue into our next topic of aneurysms. Okay, many patients with aortic aneurysms also have peripheral arterial disease. One of the most common problems affecting the aorta is an aneurysm, which is a permanent localized outpouching or dilation of the vessel wall. Aneurysms occur in men more often than in women, and in whites more often than blacks. The incidence increases with age, and aneurysms may occur in more than one location within any individual. Aortic aneurysms may involve the aortic arch and thoracic and/or abdominal aorta. The main goal of interprofessional care is to prevent the rupture of an aneurysm. So early detection and prompt treatment are essential. Surgical repair is recommended in patients with asymptomatic aneurysms 5.5 centimeters in diameter or larger. Surgical intervention may occur sooner if the patient has a genetic disorder, such as Marfan syndrome, which is a connective tissue disorder. So that's the key size, or 6 centimeters in diameter. We want to intervene before it becomes 6 centimeters, because at that point, this aneurysm is likely to rupture within a year's period. A variety of disorders are associated with aortic aneurysms. The main causes are classified as degenerative, congenital, mechanical, inflammatory, or infectious. Risk factors for aortic aneurysms include age, male gender, hypertension, coronary artery disease, family history, tobacco use, high cholesterol, lower extremity peripheral arterial disease, coronary artery disease, previous stroke, and obesity. Tobacco use is the most important modifiable risk factor. The larger the aneurysm, again, the greater is the risk for rupture. Some things we should know about aortic aneurysms includes the most common cause, which is atherosclerosis. Also, that the growth rate or enlargement in diameter of any given individual's aneurysm is unpredictable. Therefore, once identified, we monitor them with diagnostic tests to see if we can assess how quickly their aneurysm is enlarging. Now, while atherosclerosis can affect all of the aorta, it is most commonly occurring in the abdomen, and so we have many more abdominal aortic aneurysms than thoracic aortic aneurysms. Aneurysms are classified as true or false aneurysms. A true aneurysm is one in which the wall of the artery forms the aneurysm. And usually all three layers of that blood vessel become inflamed. Okay, at least one vessel layer is still intact with a true aneurysm. A false aneurysm, or sometimes referred to as a pseudoaneurysm, is not an aneurysm, but it is a disruption of an arterial wall layer with bleeding that is contained by the surrounding structures. False aneurysms will typically have inflammation of only a single layer of that vessel wall. What's very interesting to note is that false aneurysms may result from procedures that occur within a hospital setting. Sometimes they can result from a loose suture after having a CABG surgery. They can also result from removal of various catheters or cannulas within the arterial system. Here we see the example of an intra-aortic balloon pump. When we remove that cannula, it can lead to a false aneurysm. Another one, which we will see more often, is removal of the arterial cannula during cardiac catheterizations. For those true aneurysms, 3/4 of them occur in the abdominal aorta and only 1/4 in the thoracic aorta. And most of the abdominal aortic aneurysms occur below the renal arteries. Thoracic aortic aneurysms are often asymptomatic. Okay, most have no symptoms. When present, the symptoms include deep, diffuse chest pain that may extend to the interscapular area in the back. Most aortic aneurysms, being asymptomatic, are diagnosed accidentally on a chest x-ray or CAT scan that the patient had for some other condition. Symptoms of a thoracic aortic aneurysm vary depending on what part of the aorta has the aneurysm. And as it grows, it can press upon nearby structures. So the ascending aorta and the aortic arch aneurysms can cause angina from decreased blood flow to the coronary arteries. We can also see coughing, shortness of breath and hoarseness, change in voice quality, and also difficulty swallowing from pressure on the laryngeal nerve. If the aneurysm presses on the superior vena cava, we can have decreased venous return, and that will result in JVD and edema of the face and arms. Aneurysm rupture is the most serious complication. If rupture occurs, the patient can die from massive hemorrhage. When aortic aneurysms rupture, they can cause severe chest or back pain, and also can lead to losses of consciousness and even stroke, shock, or a heart attack. Abdominal aortic aneurysms, referred to as triple A's, again are often asymptomatic. They too are often found during a routine physical examination. or evaluation for an unrelated problem, such as an abdominal X-ray or CAT scan. But a pulsatile mass in the periumbilical area may be present, and bruits as well may be auscultated over the aneurysm. Again, it is challenging to find these physical changes when an individual patient is obese. If you encounter a pulsatile mass in the periumbilical region, you are not to assess the abdomen for tenderness, because this could lead to rupture. Rupture is usually catastrophic. Aneurysm rupture is the most serious complication. If rupture occurs into the thoracic or abdominal cavity, patients can die from massive hemorrhage. The patient who reaches the hospital will likely be in a hypovolemic shock with tachycardia and hypotension, as well as pale, clammy, there you go, pale, cool, clammy skin, decreased urine output, an altered level of consciousness, and abdominal tenderness. In this case, the patient is going to need immediate surgical repair. Even if the patient makes it to the hospital and the emergency room, their mortality rate is very high, greater than 50%. When rupture occurs in the retroperitoneal space, bleeding may be controlled by surrounding anatomic structures, or that tamponade effect, and that can prevent the loss of blood and death. In this case, the patient often has severe back pain. Back or flank ecchymosis may be present, and that back or flank ecchymosis is called Gray-Turner's sign. We can see a picture of that here. The most typical complaint for patients experiencing aortic rupture or dissection is a ripping sensation within the chest. They may describe it as a severe pain in the back between their shoulder blades. Other symptoms during an acute event would be similar to the presenting signs of shock, and those include things like tachycardia and diaphoresis. They may also be dizzy, have difficulty walking and speaking. In the immediate post-op period, it's going to be important to monitor hourly urine output and to further evaluate renal functioning by monitoring the BUN and creatinine levels. Decreased renal perfusion can occur from embolization of an aortic thrombus or plaque to one or both renal arteries, and this causes ischemia of one or both kidneys. Hypotension, dehydration, prolonged aortic clamping during surgery, or blood loss can lead to decreased renal perfusion. Irreversible renal failure may occur after surgery, particularly in high-risk people, patients, for example, that have a comorbidity of diabetes. patients with a history of aortic dissection require a long-term health care to control heart rate and blood pressure. Help patients understand that they need to take antihypertensive drugs daily for the rest of their lives. Beta blockers are used to control heart rate and blood pressure and also to decrease myocardial contractility. ACE inhibitors are given if the patient cannot tolerate the beta blockers. It's important for the patient to understand the drug regimen and the side effects. An acute aortic dissection is a surgical emergency. More than half of them will die within 48 hours of symptom onset. Surgery involves resection of the aortic segment with the intimal tear and replacement with a synthetic graft. Even with prompt surgical intervention, the in-hospital mortality is high. And certainly not all patients are good candidates for open surgical repair. And for these individuals who maybe have advanced age or many comorbidities, we have the option of endovascular repair. With endovascular repair, a catheter and guide wire is threaded into the femoral artery and advanced to the aneurysm. The graft then is deployed and left in place. It expands to fit snugly against the walls of the artery. Now, there is a concern that the graft may become occluded. If that is the case, then we would identify symptoms of that impaired flow of blood distal to the repair. And that could be reflected in terms of cool mottled legs or perhaps even diminished or absent pulses. Now, with the open surgical repair, we also have a problem, and we need to assess for bleeding after surgery. Okay, so again, we would want to assess our patients after surgery for either of these complications, whether it's bleeding or clotting, and that could be determined by assessment of our patient's perfusion. Sometimes this means that the patient has to go back to surgery.